Thank you. Thank you, everybody, for being here this morning. Our educational moment this morning is about the definition of acute kidney injury. And you know how we used to always call it acute renal failure, and you'll still see that term around. The new terminology, acute kidney injury, refers to the fact that once the kidney's been injured, or the kidneys, they really don't normally return back to normal. There will always be some loss of reserve capacity. So we're going to go over that definition, and we're going to study it through a case study. So how many are aware of the term acute kidney injury, right? And have you seen it used interchangeably with acute renal failure? And so it's just the fact that the terminology that in all the literature that's coming out now will refer to it as acute kidney injury, and it's just by convention by a group of people from the National Kidney Foundation who decided to redefine it. So acute kidney injury. So how many are familiar with the database called UpToDate? Okay, so UpToDate is this database in most of the hospitals. I think, for example, it's Swedish, First Hill, Cherry Hill, Issaquah, Edmonds. When you go on Epic, you can go on UpToDate, and it's a database. And it was started by a guy named Burton Rose, a nephrologist who was a professor at Harvard. And what he started doing is, when he was in the Navy in San Diego, he was making flashcards to quiz people on kidney disease questions. And so then he put this thing together, and pretty soon, probably 20 years ago, he was at the American Society of Nephrology meetings demonstrating this great tool he had. And he would sit in front of an audience and have them give him questions, and he'd look up on his computer. He had a fancy Apple computer with the fastest processors. And he could sit there and give answers to questions straight out of his UpToDate. And so then he started having a subscription service, and he started charging about $300 or $400 a year, and people would use it. And then he got certified by the AMA to give continuing education credit if you spent time on the computer. So he had a way of keeping track of how much time you spent on his database, and then you could apply for CME through his database. So now that is all available. Places like Swedish spend over $1 million a year for their subscription to UpToDate, and it's available to everybody, though, that's on Epic, for example. So this information comes from UpToDate. And so what they do is they will have authors of a section, and then they'll say this literature review is current through, and so I took this from UpToDate, and it's current through August 2017. So there could be newer information out there, but probably not too much. And so that's a good way of finding out information. The authors of this section of UpToDate on acute kidney injury are Dr. Marco Cusa, Dr. Mitchell Rosner from the University of Virginia. So first part about the terminology. So this is where I got to use the Microsoft snipping tool to take a sign that says the old way, and then I wrote in acute renal failure, and then the new way is called acute kidney injury. So what's the definition of acute kidney injury? Well, it's the abrupt and usually reversible decline in glomerular filtration rate. So you know that the kidneys are filtering, and we can measure glomerular filtration rate through something called the creatinine clearance, and it tells how much creatinine was filtered through the glomerulus, and creatinine has the characteristic of being 100% filtered, but at the level of the glomerulus, but not reabsorbed by the renal tubule. So it's a good marker for how much filtration went through the glomerulus. And so the way we can estimate the glomerular filtration rate is by measuring the serum creatinine and the change in the serum creatinine, take into consideration male or female and how much they weigh, and you can come up with what's called eGFR, estimated glomerular filtration rate. How many are familiar with that term? On the charts, when you look, EGFR.
We used to do in Montana. We used to, for our monthly conferences, we used to do that. There was a formula you can use.
Yeah, exactly. So the pharmacists use something called the Cockcroft-Gault formula, and they estimate the GFR because that tells you how reduced the kidney function is and how you have to adjust medications to compensate for that. So this is my case study, and most of us learn best by hearing stories. So this is a story. This is a story of a 28-year-old fit individual who, his activities included running 26-mile marathons. So he presented to the urgent care clinic with leg pain of 2 days duration, mainly his thighs. And his urine was dark, and in the urgent care clinic, they recognized this could be something serious, so they sent him to the Ballard Hospital emergency department. And in the emergency department, his chief complaint was sore thighs, but they were so painful that it was difficult to walk. And so his history revealed that 2 days earlier, he had participated in a spin class, and he had really turned up the resistance. And also his girlfriend was in there with him in this spin class, so he was perhaps trying to show how strong he was. and so there's this comment, someone takes this really seriously. So then, lab testing. So we said we look at the creatinine. This is 2 days later, and the creatinine still, if you didn't know what his baseline creatinine was, you could say, wow, based on creatinine of 0.8, that's pretty good. And so in the kidney world, we always look, at three things. It's really their volume status, the potassium, and the acid base as measured by the CO2. And so potassium was okay, CO2 is okay. So then we look at the urine, and the urine showed brown color, which was very definitely abnormal. Blood measured large, and protein 300, and there were some white cells in there. And this is the abnormal part. His CK, which is a muscle enzyme, we measure CK for heart attacks, but also the skeletal muscle releases CK. And normal is normal CK can be as high as 204. So if you multiply that by 10, he would be 2,040. So he was 123,000. This is huge release of skeletal muscle enzymes. So the other part of the acute kidney injury workup is always ultrasound, and ultrasound was normal. So a presumptive diagnosis was made of rhabdomyolysis. So the treatment is to hydrate, and you want to get high flow going through the kidneys and get those pigments to wash through. The myoglobin, which is the muscle enzyme released, is more soluble at a higher pH, and normal urine pH is 5 to 5.5. So they gave him bicarb, trying to get the urine pH up to 6.5. And so urine output was maintained at 200 milliliters an hour, and initially no indication for dialysis because his volume's okay. In fact, we're giving volume. His potassium's okay because the kidneys can get rid of potassium even though the muscles are releasing all this potassium. And his CO2's okay. So there's no indication for dialysis, and we hospitalize him for IV fluids. Then, so this magenta line, it represents the CK. Normal is about 200, which would be superimposable with this green line. So he comes in at 123,000. We hydrate him like crazy. He goes up to 161,000. And then he slowly comes down over 6 days. And here he is down to 10,700. So that's the CK. Then what happened to his creatinine over this time? So remember we said his creatinine started out at 0.8. So if it went up 3 times, it'd be 2.4, but he went up to 3.1. So here he is, 0.8, then he goes up, and he's 3.1 after 6 days, and then the creatinine has a characteristic pattern where it goes up rapidly, and then the slope of the line decreases, so it makes a rounded peak, and then you see him peaking here at 3.1. Then he slowly comes down to 3 and then 2.9. And this is 6 days later, so we know the kidneys are going to get better because the creatinine's turned the corner. So at this point, he gets discharged from the hospital. And then we see him back 3 weeks later, which is clear out here. But you see the creatinine has still not gone back down to normal, which would be down here. He's still this much above normal. So that's 3 weeks. And so the term acute kidney injury refers to the expected loss of renal reserve capacity. And so here he is, serum creatinine peaked at 3.1, right here, 3.1. Then after 6 days it was down to here. And then at 3 weeks it was down to here. And at 15 months it's still going down. So his kidney function is still improving, but it still hasn't gotten down to this baseline of 0.8 that we saw when he came in the emergency room. And possibly his baseline was even lower, like 0.6 or something like this, if this otherwise healthy individual. So the good news is his creatinine continues to improve. Bad news is it's never going to return to baseline. So he's always going to have some loss of reserve capacity. So the important principle is that with acute kidney injury, renal reserve capacity will not return to pre-injury levels. So that's why the new terminology, acute kidney injury, recognizing there's some permanent component to it. The injury does not result in failure to the that's of great clinical significance. We never had to do dialysis or anything like that. And the change in terminology from acute renal failure to acute kidney injury draws attention to the observation that there's going to be some residual results or injury from that event. And so this is the same slide again. The old way is acute renal failure, and the new terminology is acute kidney injury. So within acute kidney injury, you could have someone who's got acute kidney injury that's pre-renal, they're just dry and need volume, or it could be ATN, acute tubular necrosis, which is cellular injury and causing the acute kidney injury. And that's the much more serious form, and that's what this guy had. He had injury to the kidney tubules. So it'd be called ATN, AKI, acute tubular necrosis, acute kidney injury. So I wanted to talk a little bit about assessment of patients with acute kidney injury, and then the management of acute complications, because that's what we do. We do the dialysis. We have the ultimate therapy. So pathogenesis in hospitalized patients, there are usually two things involved. The first is ischemia, or poor blood flow to the kidneys, so that translates into hypotension. So usually there's a history of hypotension, and then there's a toxin. And the toxin could be something like myoglobin from rhabdomyolysis, or it could be more commonly intravenous iodinated contrast related to X-ray studies, or it could be something like nonsteroidal anti-inflammatory agents from someone who exercised hard and took ibuprofen. The other source of toxins is sepsis, because with sepsis, both bacterial cell walls release endotoxin that's toxic for the kidneys, and then when there's tissue injury, the tissue can release endogenous toxins. So the causes of acute kidney injury, either in ambulatory or hospitalized patients, it's volume depletion, it's obstruction. That's why we always do the ultrasound. And there are some less common causes, like rapidly progressive glomerulonephritis or acute interstitial nephritis, say from an allergic reaction. So the diagnosis, usually it's just simply an increase in the serum creatinine or a decrease in urine output. And by convention, definition of acute kidney injury is if the serum creatinine goes up by 0.3, so 0.3, that's acute kidney injury, or if the serum creatinine goes up by 1.5 times baseline, or if the urine volume is less than 0.5 ml per kilogram per minute. So that in a 70 kilogram person, if the urine falls to, say, less than 35 mils per minute for 6 hours, that would be considered acute kidney injury. And then, so it gets classified into 3 stages. Stage 1 is where the creatinine went up 1.5 to 1.9 times baseline. So in this case, if his baseline was 0.8, and it went up to 1.6, because 0.8 times 2 would be 1.6. So if he goes up to 1.5, he's stage 1. If he goes up to 1.6, then it would be doubling, and that would be stage 2. And if he goes up to 3 times baseline, that's stage 3. And then they have some other ways of defining stage 3. Anybody who requires dialysis, for example, is automatically a stage 3. So I'm going to just get into the summary here. The term acute kidney injury refers to the loss of renal reserve capacity. So in this guy, rhabdomyolysis, baseline creatinine at 0.8 goes up to 3.1. 15 months later, still went down to about 0.9. And the initial evaluation was to figure out what was going on, and somebody figured out he had elevated muscle enzymes based on the history and knowing to look for rhabdomyolysis. And it did require immediate action, so he got lots of volume and maintained his urine output, changed the pH of the urine so the myoglobin was more soluble, and so he got treated with fluid, and actually he did get a little volume overloaded, but not to the point we couldn't control it with diuretics. He never got hyperkalemic, which is our other indication for dialysis, and one rule of thumb, if the potassium's over 6, we normally call in the acute dialysis service to start dialysis right away, especially if the trend is that it's going up quickly. Acidosis, if pH is less than 7.1, we usually do dialysis. So the treatment, pretty simple. Volume, treat the hyperkalemia. So conservatively, without dialysis, that usually means diuretics like furosemide, or it means KX-late, get the potassium out through the bowels, or it means causing temporary transcellular shift of potassium. So we do that through insulin, dextrose, calcium, bicarbonate. And then metabolic acidosis, the pH is less than 7.1, we will give bicarb, but usually they're going to need dialysis. So urgent dialysis, volume excess, and I'd say volume's the most common reason we say we need to start dialysis, and we get clues by the chest x-ray showing pulmonary edema, low O2 sat, hyperkalemia more than 6, acidosis, pH less than 7.1. And so there's medical therapy, and then there's dialysis. So this slide is there to illustrate the point of change. So this is the eclipse of the sun on August 21st, and what you see is first you see the moon coming between the Earth and the sun, and so you see in the lower left-hand corner the crescent of the sun, and then pretty soon the sun's completely blocked in the middle, and then the change is that the moon or the sun is at a crescent on the lower portion. So change. So here are some examples of change. It went from acute renal failure to acute kidney injury. In the dialysis world, we went from hemodialysis for very critically ill patients to now we do continuous renal replacement therapy. In inpatient management or in acute kidney injury, we've now begun to transition from inpatient acute kidney injury, where we dialyze in the hospital, to, now we're starting to take care of acute kidney injury in the dialysis units. We start the dialysis in the hospital, but Medicare since January 1st, 2017 now allows acute kidney injury patients to be managed in the dialysis units. So you're going to see patients getting discharged sooner because we can do outpatient dialysis.
Then they come back to the hospital.
Yeah.
I saw that.
But we're there, and it doesn't happen with all patients, and so if it only happens a quarter of the time, the system's still way ahead. So some things don't change though. The indications for dialysis. So they have too much volume, they have too much potassium, they have acidosis or uremia. Thank you.
Thank you, Dr.
Thank you,
Ochi.
I don't know if anybody has any questions. I think I used up all my time though.
I have a question.
Yes, Connie.
So does that mean that they're getting reimbursed in the outpatient centers now because
Yeah, they're getting reimbursed, but it's a very low rate. It's probably about a fifth or maybe a third. It's a low rate, but it's not, the kidney center is just offering a service. The overall cost is of having some acute kidney injury that requires dialysis in the hospital isn't the dialysis, it's occupying a hospital bed. That's thousands every day.
It's cheaper.
So if you get them out, the system's going to be ahead. And so the Northwest Kidney Center is participating in something called an ESCO, end-stage renal disease care organization. And the idea is they figure out how much it costs to take care of these patients, and the kidney center will get something like 95%, or not the kidney center, the organization that takes risk. The organization requires hospitals, dialysis units, the personnel to take care of the patients, and then Medicare will say, okay, we're going to give you 95% of that. And there is so much opportunity there that organizations like NKC will say, okay, we'll do that, and by the way, it's going to teach us how to do it more efficiently. That's the theory, and that's the direction things are going. You've heard this term going from delivering services on a volume basis to a value basis. It's much better value if you actually can do dialysis as an outpatient. Connie, you don't look like you believe it.
For all of our kidney centers, if they have capacity, they are accepting AKI patients. So these patients should not be remaining in the hospital simply because they need dialysis, which is not the case anymore.
So this is another big change.
Yeah.
Dr. Ochi, how many
Yes.
percent recover from the kidney injury?
Oh, so this is where it's great. That's a great question. How many people recover? So, everybody likes to bring good news. And you can bring good news. And it is that over 90% of people are expected to recover from acute kidney injury. Now, recovery means not need dialysis permanently. So that's the statistic. Yeah. So if it's just kidney injury, but I can tell you the person that had open heart surgery and then they had an infection on their valve and then they had to have reoperation, their kidneys, that's not just pure kidney injury, that's kidney injury plus a whole host of other complications. The prognosis gets a little worse. But if somebody just comes in like this guy with pure acute kidney injury, you can tell them more than 90% chance that you're going to recover.
You can imagine like the bikers that do the Seattle-Portland after they do the biking for 2 days or 1 day. Some do it for 1 day. Their their result of their creatinine might be
probably is elevated a little
bit.
If you measure for blood in their urine, you could find blood.
Yeah, because that's how many people they bike for 1 day from Seattle to Portland. You can imagine that.
But these are people that are riding,
they're
75, 100 miles a day anyway.
Yeah, so
that make it in 1 day.
Keep hydrating yourself.
Yeah. Okay, well, thank you very much.
Thank you, Dr. Ochi.